Welcome, Dr. Hani.
Yeah, thank you so much. Nothing to disclose. I will talk about surgical management of osteomyelitis in diabetic patient. This is the capital of Saudi Arabia and Riyadh. Currently, I'm in Riyadh. I'm on call covering the service for diabetic foot. So my objectives here today, how to recognize diabetic foot infection and osteomyelitis. It sounds silly, but it's very hard in real life to catch diabetic foot infection at earlier stages. Recognize the classification of diabetic foot infection and osteomyelitis. How to approach diabetic foot infection without osteomyelitis. Know the most updated and expert opinions regarding the optimal treatment for diabetic foot osteomyelitis and diabetic foot infection. Diabetic foot infection, any infections related to the soft tissue, bone infection below the malleoli. As you know, diabetic foot infection increased risk of major amputation in the patient, especially if they have peripheral neuropathy and peripheral vascular disease. Diabetic foot infection, it causes burden on the healthcare system in all the world, and also burden on the patient and the patient family, and also with some psychological disruption and economic cost. Diabetic foot infection and osteomyelitis is a very serious issues in diabetic patient, and we face it every day and can lead to major lower limb amputation if it doesn't recognize earlier stages. Diabetic foot infection with osteomyelitis increase the challenge in this type of patients for the medical and surgical team, because there is no clear guideline how to manage this type of cases. Medical team, they favor their medical approach. Infectious disease, they say osteomyelitis can be treated only with antibiotics. When it comes to diabetic foot surgeon, they say osteomyelitis can be treated only with surgical treatment. So there is no clear point regarding the management of osteomyelitis in diabetic patient. Aggressive approach to manage these cases can be reduce the major amputation and increase the chance of limb salvage. Clinical assessment for diabetic foot infection and osteomyelitis. I call the diabetic foot ulcer as a volcano, because you see a small hole, but you don't know what's going inside. So you have to examine the patient very carefully. Most of the cases, they go to emergency room, and ER physician, they think this is a small wound, and they don't understand that this wound is just the beginning of the volcano. So if you examine the patient, you will find there is some of the necrosis, some of the pus going inside, or some of the osseous changes underneath the ulcer. So aggressive physical examination is really important. It's a critical factor for making decision to take the patient either for surgery or just continue with antibiotic. During clinical examination of diabetic foot wound, we have to assess of the signs of infection. We have to look, especially if it's in the plantar aspect, you have to follow the tendons and the plantar fascia, because the tendon, the infection always follow the track of the tendon. If aggressive clinical examination is a vital tool to determine the need and extent of surgical intervention. Failure to catch this infection at the earlier stage will increase the tissue damage and reduce the chance of the limb salvage. Early identification of diabetic foot infection with early surgical intervention will increase the chance of limb salvage and minimize the tissue loss. Signs and symptoms of systemic infection need to be evaluated as well. Patients with a diabetic foot infection frequently present with uncontrolled diabetes. Physical examination is the really key in diagnosis and early recognition of diabetic foot infection. There is a multiple classifications. This is the most convenient between IDSA and International Work Group of Diabetic Foot. They classify diabetic foot infection according to the sign and symptoms of infection. There is another classification. This was taken from Dr. Zagona's book. They classify it as non-limb threatening or limb threatening infection. I made this to make it simple for you. I classify my patient either mild/moderate diabetic foot infection. If the wound is superficial ulceration with or without osseous involvement and ischemia, if the redness and erythema cellulitis less than 2 centimeter and the patient medically stable, this patient can be treated as an outpatient in the clinic. Also, you have to do foot x-ray even if you don't think if there is osteomyelitis. As initial visit, you have to keep it as a baseline, and then you can do minor debridement after checking the vascularity if the patient has intact vascularity, and then continue with wound care, offloading, and start the patient on oral antibiotic after taking the culture and re-evaluate the patient. If the patient improve, and then you continue as an outpatient. If the patient doesn't improve, and then go to the next step. If the patient has severe diabetic foot infection, like a deep ulcer, abscess, erythema more than 2 centimeter, lymphangitis, necrotizing fasciitis, osteomyelitis, medically unstable, ischemia, and gangrene, we have to start a multidisciplinary approach. We have to call our colleague, infectious disease, vascular, medical team to optimize the patient medically, to optimize the vascularity, to start the patient on empiric antibiotics until we have our results of the culture, and early surgical intervention without any delay, because delay in management of diabetic foot infection can increase the chance of sepsis, septic shock, and major amputation. Indication for hospitalization if the patient has, if it doesn't improve as an outpatient, if the patient needs intravenous antibiotic, if the patient needs more advanced imaging, if the patient needs any vascular procedure, if the patient presents with a severe systemic infections. So our rule, if the patient has infection, first we have to clear the infection, and then assess the patient from the vascular status standpoint. If the vascular is good, and then we'll take the patient again for reconstructive surgery and stabilize the patient foot. Diabetic foot osteomyelitis, the triad of diabetes, ulceration, and osteomyelitis has increased in the prevalence, are now major cause of non-traumatic lower limb amputation. We can reduce the amputation if we control the diabetes and we manage the patient at the earlier stages. Urgency and consequences of diabetic foot osteomyelitis are well understood, but the issue about the treatment plan and how to manage this patient. Peripheral vascular disease is increasing the risk of major amputation in the patient with osteomyelitis. There is a multiple classification for osteomyelitis: medullary, superficial, localized, and diffuse. But in the real life, nobody is applying this osteomyelitis in diabetic patient, and it's rarely used in diabetic foot osteomyelitis. Bone culture and biopsy is needed to identify the organisms before to start the antibiotics. So now, most of the people they ask, do we do surgical treatment for osteomyelitis or to do medical? In my opinion, and from my humble experience, I think both needed in treatment of diabetic foot osteomyelitis. Current recommendation in the literature, in research, based on the expert opinions and experience from the diabetic foot surgeon. There is also issues for the duration of antibiotics. Either you start the patient in 6 weeks, 6 months, 3 months. Still, there is a debate on the duration of the antibiotics. The issues with the antibiotic for long period of time can cause a lot of complications, Clostridium deficit, and also can causes chronic kidney disease. And some of the patients, they develop allergic reaction to this antibiotics. So from my experience, if you are sure that you resect the osteomyelitis and the bone clean, usually we keep the patient on 2 weeks antibiotic. If you think still there is infected bone, there is infection, you can keep the patient on antibiotic for 6 weeks and to make sure the infection is clear. How we assess the progression of osteomyelitis: if the wound is completely healed and the wound is progressing well, an inflammatory marker is going down, that's the signs the patient responding to your treatment plan. So I think in diabetic foot osteomyelitis, there is no pure treatment only with medical or pure treatment with the surgery. With the surgery, I think both surgical and medical treatment should be involved in diabetic patients. IDSA reports some of the guidelines that some cases of diabetic foot osteomyelitis can be treated with osteomyelitis. If there is a surgical resection, can cause excessive loss of function. If there is an unreconstructible vascular disease and trying to avoid amputation, risk of surgery too high in the patient with the multiple comorbidities. And they say forefoot osteomyelitis. I disagree with this, because sometimes we have to intervene, resect the osteomyelitis in the forefoot, and then we keep the patient for antibiotic for 2 weeks, depending on the severity of the infection. Limitation of medical approach, as I mentioned earlier, long duration of antibiotics, drug-related side effects including Clostridium difficile, diarrhea, and emergency of antibiotic resistance organism. The risk of relapsing due to infected bone tissues, sterilization of which can never be affirmed. The persistence of bone deformity at the origin of the foot ulcer. So we have to correct the deformity in order to prevent the chance of recurrence. All potential weakness of antibiotic therapy can lead to that surgery should be considered in the management of osteomyelitis. Surgical resection of affected bone recommended when any of the following is present: if there is systemic signs of infection, open infected joint space, presence of prosthetic heart valve, a clinical or imaging evidence of cortical disruption or osteolysis, evidence of macroscopic bone fragmentation, necrotic bone, or exposed bone. So expert opinions, Zagonans recommended early and aggressive surgical intervention in order to save the patient limb and reduce major amputation. Henke conclude that surgical debridement was associated with a greater wound healing. Van conclude that surgery would shorten healing time as well as reduce need for long-term antibiotic therapy and limiting emergence of resistant strain. Tan and his colleague reported lower rate of above ankle amputation in patients who underwent earlier debridement or local limited amputation than in patients treated with solo antibiotic therapy. Most experts do not agree with the forefoot osteomyelitis and should be treated by antibiotic. That's what I said. If you have a forefoot osteomyelitis, it should be resected, and then you can keep the patient on antibiotics for 2 weeks. There is uncertainty regarding antibiotic duration in midfoot and rear foot, especially in the calcaneus, because as you know, the calcaneus is a cancellous bone. This type of patient, they need aggressive debridement and longer duration of antibiotic therapy. Take-home message: careful and thorough physical examination is very critical for decision-making regarding treatment plan. Lower extremity osteomyelitis is a primary surgical disease. Aggressive surgical approach to diabetic foot osteomyelitis and infection shorten healing time and reduce the need for long-term antibiotic therapy. Reduction of reinfection rate was noted and confirmed with early and aggressive surgical resection of all infected bone in conjunction with a brief course of antibiotic therapy. Osteomyelitis in calcaneus bone require more extensive debridement with a longer period of antibiotic therapy. This concludes my presentation for diabetic foot osteomyelitis. Thank you so much.